An introduction to sectional anatomy and the thorax. So before we begin actually looking at sectional anatomy, I feel that there are some necessary things that we need to understand. Number one is the four anatomic planes of the body. And many times we'll see that this becomes the way that we reconstruct images. We have the sagittal, the coronal, the axial or transverse, and the oblique. The axial is typically what we scan in and what you will see scans acquired in, and the other three are things that we can actually do in terms of reconstruction and processing images. As we'll see, if we are looking at the body in front and back, so this being front and this being back or posterior, we see that the coronal plane divides front and back. Also, we see that the sagittal plane divides right and left in terms of looking at CT images. Also, we see that oblique is just that, it's an oblique plane, and I'm sure we all understand oblique from our experience in radiography. And lastly is axial. Axial occurs when the patient is laying supine, and it divides sections of the body. Let's say that this will be cephalic, and this will be caudal here. And so it divides images in terms of this plane, and it'll become more apparent as we actually look at images. Another thing that I would like you to understand is, and I feel that it will be very beneficial in terms of looking at anatomy, is the terms in Table 1.1. In addition to Table 1.1, also know the terms in Table 1.2 as well, as they will become useful as we progress through this course.
Okay, we see that there are two main sections of the body. There's the dorsal and ventral section. The dorsal is located posteriorly and includes the cranium and the spinal cavities. This includes such things as the spinal cord and the spinal column. The ventral section is the largest body cavity, and it's subdivided into two certain sections. Those are the thoracic, which contain two pleural cavities, and the mediastinum. And so this is typically what we're striving to attain on chest CTs. Second is the abdominopelvic cavity, and as the name implies, it has the abdomen and pelvic cavity, and we'll see this embodied throughout our lectures. Also, it's very important that we see that there are 9 regions of the body, or of the abdomen. We see that we have what almost looks like a tic-tac-toe pattern here, with lines going here, 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 and here. So basically, if we begin in the center here, we have the umbilical region. And then up above the umbilical region is the epigastric region, and below the umbilical region is the hypogastrum. To the right of the umbilical region is the right lateral, and to the left is the left lateral. Above the right lateral is the right hypochondrium, and below the right lateral is the right inguinal. And this follows much the same pattern for the left side, with above the left lateral being the left hypochondrium, and below is the left inguinal. We see that the body can be divided into right and left sections by the right midclavicular plane here and the left midclavicular plane. So that divides us into sections here. And then we have the transpyloric plane and the transtubercular plane here. And when we actually see anatomy, it will become more apparent to each of you why this is and how this actually fits into the layout of the body. But just for now, just know the simple diagram and really know the 9 planes or 9 regions of the body. That's the real point that I want you to get from this. So know the 9 regions. So the bony thorax. We'll find that the reason we begin with the thorax and not some other portion of the body is that I find that the thorax is very simplistic, and it sets a basis for looking at computer tomography images for the rest of the lectures. And so I feel if you begin with something simple, then when we get to things such as the cranium and the brain, things become more apparent because you have a basis to build off of. And so we're going to begin by looking at simple things which should kind of stand out to you. So the bony thorax is made up of the sternum, ribs, and spine. And so just remember that these 3 things make up the bony thorax. If we'll also notice that each of these things have a protective function in mind. The sternum anchors both the ribs, both sides of the ribs together. The ribs actually serve to protect the vital organs of the body, and the spine serves as another anchoring point and also helps provide a rigid structure for the body and also enables flexibility. And so all of these things are very important, and the bony thorax is also very important to the vitality of life. So if we begin with the sternum, we see that the sternum is made up of the manubrium, body, and xiphoid process. Notice that the sternum begins at the jugular notch at around T2 to T3. So this becomes a very important bony landmark to allow you to see where things are. We also see that the sternal angle is where the manubrium and the body join, and it's located around T4, T5. And so keep both T2, T3, and T4, T5 in mind so that you will be able to find bony landmarks and enable better patient positioning. So we'll begin with this first picture, which is just a basic sagittal view of the sternum, and if we'll notice, it replicates the lateral view of a sternum very well. If we refer to the images on the right, we do see that we have a sagittal plane running here, and that is where our image is actually located. And then on the axial images here, we do find that we still have the sagittal plane running there. So let's get rid of these lines, and then we'll refer to this image over here. We do say that around here is T2 or T3, and then around here is 4 or 5. So keep that in mind, and let's look at the anatomy that we really need to know from this. We do see the manubrium, and so we need to know the manubrium, and the manubrium is this area here. We also see the sternal angle, which is here, and notice that it creates a prominence right there due to the joint. And then the longest portion of the sternum is the body, which compromises this large portion. And then lastly, we have the xiphoid process. And so the xiphoid process is located at the very tip of the sternum, right around here. And notice how very thin it is. But also take a good look at how nice this image is, because even on our best day, we could not attain this with simple radiography. And so this is one of the added benefits of CT, imaging bones very, very adequately. So in review, the only structures that we need to learn from this are the manubrium, sternal angle, sternal body, and the xiphoid process. So I think on this image we can really get a better idea of where things are. It has some things that we haven't talked about, and we will kind of refer back to this image when we return to that. But notice that we do have the sternum here. And so looking at it from the coronal perspective, we have the large manubrium. And then after the manubrium, we have the sternal angle. After the sternal angle, we have the sternal body. And then after the sternal body, we have the xiphoid process, which is here. Also take notice of where everything actually is located. We do see that the sternal angle is around the second rib, based on the way the location of the body is. However, it does line up with T4 usually. Also, we do see that the jugular notch is around here, around T2. And then there's other things that we haven't talked about and we'll refer back to in terms of the sternum. So the ribs. We see that the ribs are made up of a head, neck, tubercle, and the body. And they're located from T1 to T12. And as we see, there are certain delineations of ribs. We have true ribs, false ribs, and floating ribs. And we see that that's all dictated by their attachment and how they actually attach to the sternum and what type of cartilage they actually use. But the same basic structure of the ribs actually are maintained. We do see that we always have the head, neck, tubercle, and a body. And we'll see that throughout our images as well.
Okay, on this image, we do see that we have the ribs lying in this plane here. Okay, so one thing that you'll notice very quickly is that it becomes very hard to delineate between which rib is which. We know left and right, but we also don't have a clear understanding of where these ribs are actually located in terms of the body. So we don't know what level these correspond to. One thing that comes in handy on this is looking at the SIR view and using the scan positioning lines to actually determine where you're at. Or also you can reference this based on coronal and sagittal reconstructions as well as axial. So we do see the ribs here. And one thing to notice is this area on both sides. This is the costal cartilage, which serves as a point of attachment for the rib and the sternum. We do see that we have the sternum lying in the center, just anterior to the heart. And then if we look at the posterior portion of the image, we do see that we have a thoracic vertebrae here. And going even a little deeper in terms of this, we do see that we have the vertebral body here. And there is an articulation between this rib and the vertebral body, and that is right there. So if we remove all of these lines, we do see that the head of the rib articulates with the vertebral body, and this forms the costovertebra joint. and we don't see the costotransverse joint. Perhaps in some other images we will actually see this. I know in future lectures we will actually go over this as well. So it becomes something to build off of in terms of knowledge. But in terms of things that I would like you to know from this image, we do have the obvious. We have the body of the sternum. We have the costal cartilage. And then we do have a rib. And then we have the head of the rib, thoracic vertebrae. And something that I failed to mention is the angle of the rib. If we'll notice in the posterior portion, it curves. This corresponds to the angle of the rib in the posterior segment of it. So certainly know the angle of the rib, and also the neck of the rib. As we know from just looking at the human body, we see that the head sits on the neck, and this is much the same. We have the head here, and then we have the neck directly below it. And so very obvious there, not a new groundbreaking area of information. Also, in addition to the neck of the rib, we'll also look at the heart. And so in terms of this image, even though we haven't actually talked about it yet, we do have the left inferior pulmonary vein, the aorta, the right inferior pulmonary vein, left ventricle, right ventricle, left atrium, and right atrium. And so these are each things that I would like you to know from this image, and we'll discuss the cardiovascular points here in a few minutes. As we look at this image, we see that we have a little farther up, a little more proximal to the head, is this image that is acquired. If we begin simply by looking at the ribs, we do see that we have a complete thoracic vertebrae here. And if we notice this area, let me erase that. That's this area here. We do have the costovertebral joint. And then we also see that we have the transverse processes both here and here. And so we can presume that this articulation that exists here is going to be the costotransverse joint. Also, another important thing to recognize is the location of the trachea. The esophagus we're not going to really worry about because it's really not demonstrated very well here, and I feel that can be sometimes confusing. But we do want to see the trachea, and notice how the trachea is the air-filled structure right here, and it is just posterior to this structure, which we call the aortic arch. Another piece of anatomy to actually notice is the superior vena cava. And if you notice here, the superior vena cava is much wider in appearance than the aortic arch. And probably the reason for this is because the contrast injection is flowing into the superior vena cava. And so we're still receiving tons of contrast through that, whereas the aortic arch hasn't got as much contrast in it at the moment. Also, we have the manubrium here, corresponding with this structure. And one of the most overlooked areas is the thymus, which is here. And it corresponds to this area. Notice that it's just slightly anterior to the aortic arch. And as we know from previous experience, performing conventional radiography on children, the thymus gland is very large at a young age. However, it tends to not enlarge itself and does not grow, and actually winds up shrinking over the course of time to the point to where it's very, very tiny to see. But look for it at the level of the aortic arch. So you'll see a space somewhere in this area around the aortic arch, and that will be where the thymus is. So in total, looking at all of these images, basically the anatomy that I want you to know from this is the aortic arch, thymus, manubrium, superior vena cava, and the trachea. Don't worry about the esophagus here. So continuing on with the ribs, we have intercostal spaces, and so that is the space between adjacent ribs. And so if we were looking at a patient's rib cage, we would see that we have perhaps one rib here and another rib and another rib. The space in between here and here would be the intercostal spaces. Additionally, we have the costovertebral joints, and that is where the facets of the head of the rib articulate with the vertebral body. So keep that in mind and know that. Also, the costotransverse joints. This is where the transverse processes of the vertebrae articulate with the facets of the tubercles. So simply know that the costovertebral joints is the head of the rib and the vertebral body, and the costotransverse is the facets of the tubercle and the transverse process of the vertebrae. And so there's a key difference there between the two, and it would be very easy to get confused. However, if you break it down and look at the names and you draw a line between costo and transverse and costo and vertebral, then you actually can get a very good handle on what actually each joint actually is and what it articulates with. So in this diagram of the articulations of the rib, we do see that we have a very simple layout, and many times on CT it's not as cut and dry, and you won't see this all on the same plane, and so it becomes sometimes skewed, but the same anatomy still holds true. Once again, we have the sternum in the center, which is here, and then to the right and left of the sternum we have costal cartilage, and remember that this is the cartilage that actually attaches the sternum to the ribs and kind of holds everything together. Then we have various parts of the rib. We have the sternum end, we have the body, and then we have the angle, and then we have the neck and the head. And so remember all of these parts of the rib. Remember that the sternum end is what it implies, at the sternum end. The body is the majority of the rib, all the way from the sternum end to the angle. The angle is where it actually makes the sharp turn to go anterior, and then we reach the neck, and that leads to the head. So just remember those key points here. Additionally, this image does provide us with a means of looking at the vertebral body and the vertebrae in general, and looking at the articulations that happen here. Once again, we do have this articulation, and we do have an articulation here. This articulation is the costovertebral joint, and this articulation is the costotransverse joint. It becomes very easy to remember because the costotransverse simply articulates with the transverse process. The costovertebral joint articulates with the body. And so just keep those in remembrance, and it will really help simplify what you're looking at in terms of thoracic CT. So in all, on this image, the anatomy that you really need to know pretty much comprises all of the image. We need to know the sternum end, the sternum, costal cartilage, the body, the vertebral body, the head, tubercle, neck, costovertebral joint, angle, transverse process, costotransverse joint, and vertebral end. I forgot to mention that the vertebral end is much like the sternum end, with the exception that the vertebral end is going towards the body. And so just remember there are two portions of the rib. As we saw in some previous images, we do see that the thorax has two apertures, or points of entry and exit out of it. We do see that we have the thoracic inlet, which allows for the passage of nerves, vessels, and viscera from the neck into the thoracic cavity. So in terms of looking at the thoracic inlet, it is what is going to allow things to go from the head into the thorax. We also do have the thoracic outlet, and it allows for the passage of nerves, vessels, and viscera from the neck out of the thoracic cavity. And so basically it allows things to exit out of the thoracic cavity, and we'll see that the thoracic inlet is very tiny. Let me erase that. And the thoracic inlet is very tiny, the thoracic outlet is very large. And so that's why we have this type of appearance to the rib cage, more flared at the bottom than at the top. As we return back to this image, one thing that I would like you to take note of is the thoracic inlet, which is here. And notice how small it is, because it is limited by the first rib. And as we see, the first rib kind of constricts very tightly, doesn't allow a large opening. And if we kind of return out, we do see that we have the thoracic outlet. And as we'll notice, the thoracic outlet is very much large. And that is why we have a certain type of appearance to the rib cage like this. Because there are much more things that are going on outside of the rib cage as we descend down than there are things that need to come into the rib cage from the neck. And so it's very important that the rib cage has this type of structure, because if it were the other way around, it would be very, very unprotected. And notice that the more constricted areas are up higher where your heart is. And so if your heart is around in this area, we will see that the ribcage functions best in terms of being shaped like this. It offers the greatest amount of protection. So just know what the thoracic inlet is and what the thoracic outlet is, and where they are in location to the body. The lungs. As we know, there are several portions and parts of the lungs. First, we begin with the apex, which is the top of the lungs, and the base is the bottom of the lungs. So if we look at a rudimentary drawing of a lung, we see that this is the apex, and this wide portion here is the base. Additionally, we have lobes of the lung which subdivide the lungs. The right lung has 3, the left lung has 2. And so keep that in mind. Right has 3, left has 2. We do see that we have an oblique fissure which separates the superior and middle lobes of the right lung. So on this image, as we can see, we are still pretty much proximal to many of the structures in the thoracic cavity. We haven't actually seen the heart come in, although we are seeing the aortic arch. And so, number one, let's just kind of go through the structures that the image actually has labeled. We do see that we have the right lung here and the left lung here. And while it may seem contradictory to what we would typically look at an image, we do see that when we're looking at CT, your left becomes the patient's right, and your right becomes the patient's left. And so it all becomes pretty much reversed. So keep that in mind, that over here is the right lung and here is the left. And notice that we do have markings here and here which help to delineate this. We also do see that we have the aortic arch, which is not labeled in this. We do have the body of the sternum. We've probably just gotten past the sternal angle, and we are getting the body now. Additionally, we do see that we have vertebral body here, and we do have the costovertebral joint here, and the transverse or the costotransverse joint here and here on this image. Additionally, we do have this structure here, which is the trachea, and we do have the thymus in this image as well. So keep that in mind, and use something like this to help review your anatomy so that you can better understand it. That's not labeled when we get done with the lecture. We haven't spoke about it yet, but there are two pleura. There is the visceral and the parietal pleura. As we know, the visceral pleura pretty much covers the lungs, and there is a space between the parietal and the visceral pleura. The parietal pleura basically lines the thoracic cavity, and in this space, the pleural space, there can actually build up more and more fluid. And just as we see a pericardial effusion, we do see that we can have a pleural effusion as well. And that's what we see in this area here. Notice that there is a drastic change between the lungs here and the rib here. This lung at the posterior portion is what we typically would want to see and what we would like to see it looking like. And so this is a pathology on the left lung. This image becomes slightly more complex. Although we haven't actually spoke about it yet, we do have the ascending aorta here and the descending aorta here. And so just slightly more proximal is the aortic arch, which connects the two. We do see that we have past the corona, or the bifurcation between for the trachea, and we do have right and left mainstem bronchi or bronchus here, which we will review the order of respiration in just a few seconds. Also, we do have this structure here, and many times this is what the pulmonary trunk will actually look like, with this being the right pulmonary artery and this being the left pulmonary artery. And as you will find out, there are many times that we're looking for a pulmonary embolism, or a PE study is performed, and that's where we're actually looking for it at, is in one of these areas here. So keep that in mind, and we'll review this later and we'll go more in depth. Also, we do have the superior vena cava, and notice that this is a contrast enhanced study as well, and the superior vena cava has much more contrast enhancement than the previous than the ascending aorta. Additionally, look at the costotransverse and costovertebral joints as well. Also notice that we are in the body of the sternum, and we do have costal cartilage right here and here to connect the ribs to it. So in looking at this image, there are a few key things that we want to actually notice. We want to know the superior vena cava, the pulmonary trunk, left mainstem bronchus, left pulmonary artery, descending aorta, right mainstem bronchus, right pulmonary artery, and that will suffice in addition to the other anatomy that we spoke of here. So notice that we have pleural cavity. Pleura is a serous membrane that lines the pleural cavity, and so that's really what it's made up of. Parietal pleura is the outer layer continuous with the thoracic wall and diaphragm. Visceral pleura is the inner layer, and it covers the individual lobes. And the interpleural space is the area between the pleura, and it contains liquid to combat frictional forces. So if we were looking at this, we would say that this would be the visceral pleura here, and notice that this is the lungs, and so it's pretty much contiguous with the lungs. And so we would have a space, and then this would be the parietal. And so this space in between is the interpleural space. And to combat the frictional forces which could potentially cause a great deal of damage to the lungs, there's fluid that lines this which helps reduce this frictional force and allows the lungs to expand and contract at proper rates. And so without this fluid, respiration becomes very painful and becomes almost impossible. And so keep that in mind, the difference between the parietal and visceral pleura. So this image seeks to kind of put everything into perspective. And so we have lung here as being traced by this yellow. Okay, and so pretty much the outer layer of the lungs is the visceral pleura. So keep that in mind and know this, the visceral pleura. So we also do have lining the thoracic cavity, the parietal pleura. And as we can see, there is a space in between as designated by the white where fluid exists. And once again, this is the intrapleural space or interpleural space, which allows the lungs to actually expand. And so just remember this and keep this in mind and know both the visceral and parietal pleura. So the order of respiration. Number 1 is the trachea. Number 2 is the left and right mainstem bronchi, which are located at T5. So keep that in mind, T5. Number 3 is the lobar bronchi. Number 4 is the tertiary or segmental bronchi. Number 5 is the bronchioles, and lastly is the alveoli. And it's important to understand the functional properties of the alveoli, and so we must understand that they are the functional units of the respiratory system. Gaseous exchange between the alveolar air and capillary blood occurs through the wall of the alveoli. However, if you have a disease such as COPD or emphysema, which causes constant expansion of the alveolar air sacs and doesn't allow them to expand and contract, only keeps them in a state of constant expansion, then we see that respiration abilities and functionality rapidly decreases. We see that with very short amounts of activity, respiration rates fall well below the normal and can be very detrimental to the patient's health. And so we see that patients who have difficulty or problems with the alveolar air sacs ultimately wind up having compromised perfusion of oxygen and ultimately have great difficulties breathing. So if we refer to this image now, we see that we're going to use it for the order of respiration. So number 1, we have the trachea, and so we will put a number 1 beside it. And so as air flows down, we go from the trachea and then reach this point here. We have a bifurcation, and this bifurcation is called the corona here. The corona divides the trachea into left and right main stem bronchus, and so we have number 2 here. This main stem bronchi then becomes the lobar bronchus, which are really not designated here. Then it becomes the tertiary bronchi, and then we ultimately work our way out into the alveolar. And so just remember the order of respiration, and pretty much the only thing that you need to know from this image is the apex of the lung, the trachea, the left and right main stem bronchi here, the corona, and that will suffice. So that brings us to the thymus. The thymus is a triangular shaped bilobed gland of lymph tissue. It reaches maximum size during puberty and gradually diminishes in size after that. It's located in the superior portion of the mediastinum, just behind the manubrium. It produces a hormone called thymosin, which is responsible for the development and maturation of lymphocytes. So if we were to look at what thymosin actually produces, we see that it's involved in the production of lymphocytes. And we must connect this with the thymus gland being a lymph tissue gland or an organ. And because of this, we know that it plays a very important function in immunity. Another thing to keep in mind, besides the fact that it's a lymph tissue gland, is that it reaches its maximum size during puberty and then gradually diminishes after that. Many times, as if you're doing just a routine chest radiograph on an infant or someone very young in age, you see that the thymus is very predominant and it takes up the large majority, and it almost makes the heart look vastly enlarged. And that's simply just because of the thymus being so large in relationship to the other portions of the body. And as the body continues to grow, the thymus seems to shrink. And we actually see that it reaches maturation during puberty and then shrinks from then. On this image, we see pretty much a sagittal view throughout the thoracic cavity. We do see that we have the heart being in this area here. Additionally, we do have the aortic arch here, and then the descending aorta here. But if we actually remove ourselves from the heart, we actually see other structures as well. We do have the manubrium of the sternum here, the sternal angle here, the xiphoid process or xiphoid tip in this area. We also see that we have the trachea coming down here, And then coming into the mainstem bronchus, and we know that we have left and right mainstem bronchus, but we're looking at this from the left side, so we're actually seeing the left mainstem bronchus here. Additionally, we do see that we have the thymus here, and we can look at the areas that it actually corresponds to. There appears to be a line running here at the sternal angle going back to T4, T5. So it's usually at this level that we can presume about the midpoint of the thymus gland. Additionally, if we refer back to the heart now, we do see that we have the inferior vena cava here. And also we do have the spine in this area here, which is the posterior portion of the body. We do have C7 through L1 here, and these landmarks will become more important as we continue throughout the body. In looking at the heart, we also must see that the heart is made up of several tissue layers. We have the epicardium, the myocardium, and the endocardium. So if we actually break these words down into just pretty much the roots, we see the epi, we have epi, myo, and endo. And so epi means above, which pretty much relates to where the location is of this tissue layer. We see that it is the thin outer layer of the heart wall, and it is in contact with the pericardium. And so it is what comes up to the serous pericardium. We also do see that we have the myocardium, which is, as myo would allow you to believe, is the middle layer of the heart tissue or heart muscle. It is the thick middle layer consisting of strong cardiac muscle. And so when we think of the heart pumping and the heart being a muscle that really pumps and forces fluid out, we're really thinking of the myocardium, because one thing that we'll keep in mind is the epicardium and the endocardium are both very thin layers. And so we rely on the myocardium because it's the very strong cardiac muscle, and it's what generates all of the force for the heart. The endocardium, as the name implies, it is the thin endothelial layer lining the inner surface. And so it's a very smooth surface which provides less friction for blood and fluids to actually come into the heart. We also cannot forget that we have an intra-atrial septum, and as the name implies, it divides the atrium. And so we would think about it being one atrium here and another atrium here, and it is a dividing line that runs up and down that kind of divides them. And it's much the same for the ventricles, because we do see that we have an interventricular septum, and it divides the ventricles. So if we would think about this being right and left, then we would see that we have a line that, or a wall that pretty much separates the ventricles and the atrium from each other. So that's something to keep in mind, and we'll actually see this exhibited really well in terms of CT images in the future. So before we actually begin looking at the heart and all of the mechanisms that are involved in the heart, I feel that it's necessary to actually demonstrate to you how blood actually flows into the heart and exits the heart. Because it's very imperative that we actually understand how the heart functions. So if we begin with blood actually returning back from the IVC, which is the inferior vena cava, and the SVC, the superior vena cava, we do see that it has to pull somewhere. And this place where it kind of dumps everything into is the RA, or the right atrium. From the right atrium, it flows into the right ventricle, or the RV. From the right ventricle, we would still think that, well, it's deoxygenated blood. It should flow through the venous system before it can get to the arteries. However, this is what is very unique about the heart, and is actually one of the only arterial systems to actually carry deoxygenated blood. The other involves women who have become pregnant, and the arterial system there that supplies the fetus. However, in terms of just normal, everyday human beings, the pulmonary arteries are the only ones that actually carry deoxygenated blood. And so we get to the PA, the pulmonary arteries. From the pulmonary arteries, blood flows out through all of the lobar branches, subsegmentals, and actually gains oxygen through the arterial system, and oxygen is put back into the blood. And so we see that the pulmonary veins carry oxygenated blood back to the left atrium. From the left atrium, we see that blood flows into the left ventricle and then gets pushed out through the aorta. And so while this is a very crude, rudimentary drawing here, I do feel it's necessary that we understand this basic schematic of how the heart actually functions, so that we can better appreciate and actually understand where things are going. Also, this will make us much better techs, so that we can understand where blood flow should be at certain moments, and how we can best catch contrast boluses and demonstrate them very adequately. So, if we begin looking at the right atrium, there's a few key things that we must understand. Number one is that it forms the right border of the heart. As the name implies, right atrium, right border of the heart. It receives deoxygenated blood from the body via the superior and inferior vena cava, from the coronary sinus and cardiac veins that drain into the myocardium. So that's something that I left out in the previous drawing, but also know that the coronary sinus and cardiac veins drain back into the myocardium, that actually helps pump the blood out and drains it back in to the right atrium, so that it receives oxygenation, so that it can keep the heart muscle alive in itself. So that brings us to the right ventricle. We see that it lies on the diaphragm and comprises the largest portion of the anterior surface of the heart. So the right ventricle is a very large ventricle in itself. It receives deoxygenated blood from the right atrium and forces it to the pulmonary trunk for conveyance to the lungs. And so when we're talking about pulmonary trunk, we're also including the pulmonary arteries here as well, because before they actually become the pulmonary arteries, the right and left pulmonary arteries, they begin as the pulmonary trunk. So it's very important that we still understand this. So that brings us out of the pulmonary trunk and the pulmonary veins back into the left atrium. We see that it lies posterior to the right atrium and is the most posterior surface of the heart. So that's something to keep in mind, that the right atrium is more anterior. So we're going to call it anterior. And the left atrium is post. And so just think about it that way, that the right atrium is anterior, the left atrium is post. And so you can say that the right atrium is ant and the left atrium is post. Also, we see that it receives oxygenated blood directly from the lungs via the 4 pulmonary veins. So keep that in mind as well, that there are 4 pulmonary veins. There is superior and inferior pulmonary veins on the right and left side, and so that's how we actually get 4. But just keep in mind, left atrium, oxygenated blood. So that brings us to the final portion of the heart, which is the left ventricle. It's the most inferior portion of the heart, and it pumps oxygenated blood into the aorta. And the really key point here that we want to make is that the myocardium is normally 3 times thicker than in the right ventricle. And so keep that in mind, 3 times thicker. What 3 times thicker actually means is that while the right ventricle is very important in getting the blood to be oxygenated, there's not this demand for the right ventricle as much as there is the left ventricle, because you got to understand that the left ventricle has to contract with such force that it pushes the blood up through the aorta, goes out into the carotid arteries and subclavians, and actually pushes blood up into the neck to supply the brain, to supply the extremities, and also to push blood down through the abdominal cavity and supply the abdomen and the lower extremities. So the left ventricle is the ventricle that it has to be the most powerful. And not only does it have to be the most powerful, it is the ventricle that if damage occurs, the heart just does not function very well. Because when the left ventricle does not function, the heart has a tendency to back up in itself. Because if you think about it, if the left ventricle is not pushing any fluid or blood out of it, then that blood has to go somewhere. And so it's going to start being piled back up into the left atrium, and then as a result into the pulmonary veins and the pulmonary arteries. And then all of a sudden you start having pulmonary edema, and then you start having pleural effusions, and then your body just can't handle the backup here. So the left ventricle is very important to keep in shape and to actually not suffer damage. We must also not forget that the heart has several valves and valve systems in it. And these valves all have one thing in common, and that is to prevent the backflow of blood into another area that it's not supposed to go back into. And so if the heart did not have these valves, we would have to say that the heart would be very inefficient, because of what we all know from physics and from various portions in life, that when you're trying to push something out, it's going to go into the pathway that has the least resistance. And so the heart is trying to generate all this force to overcome the resistance that the body's trying to place on it. And the fluid will unintentionally find ways to get around this high pressure system. And so we would see that the atrium would be relaxed at this portion in time, and so the heart would use the ventricles to actually push blood back into the atrium, and so thereby decreasing the efficiency of the heart by a lot. And so we see that the valves are very, very necessary. And so we do see that we have the right AV valve, or the atrioventricular valve. and we see that it's tricuspid, and it has 3 leaflets. The left AV is bicuspid and has 2 leaflets. So keep that in mind, that tricuspid means 3, bicuspid means 2, and that the right is 3, the left is 2. And so just keep this whole portion in mind. Also, the heart has semilunar valves. And we see that where the atrioventricular valves are tending to separate the atrium from the ventricles and to keep blood from flowing from the ventricles back into the atrium, the semilunar valves have the same function but just in a different location. We see that the semilunar valves are located at the junction where the ventricles meet the great vessels. And by great vessels, we mean the pulmonary trunk and then also the aorta. And so, looking at this, we see that the pulmonary semilunar valve is between the right ventricle and the pulmonary artery, or the pulmonary trunk. Very simple. The aortic semilunar valve is between the left ventricle and the aorta. And so, by simply knowing how blood flows in the heart, then we can start to make sense of where these valves are located. Also, one thing that I wanted you to keep in mind is the chordae tendineae, which is thin cords that attach the leaflets of the valves to the papillary muscles. And so this helps to open and close the valves. And so the heart is pretty much your one-stop shop for the blood pumping. Everything is contained in itself, and it's a very complex pump, but it does it very, very well. And so because of this, we see that we have to have these things such as strong myocardiums, such as valves that separate the ventricles and the atrium and the great vessels from the ventricles. And so by doing this, we have a very efficient mechanism for pumping blood out into the body. And so this is why it is very necessary. So just keep this in mind, the pulmonary and the aortic semilunar valves. Now we start actually looking at images, because we can know all of this stuff, but if we don't know what it looks like on CT, then it really becomes all for naught. And so we do see that we have several pieces of anatomy here that we need to just get out of the way. We do have the descending aorta here, and the reason we say that it's descending aorta is because, number one, we can look at this nice handy picture over here, that's sagittal, and we can see that it's going down. We're not at the ascending aorta here or the aortic arch there. However, one way that we can actually look at it just by not referencing any other image than what we're actually looking at is we don't see any of the curve. And we're actually going down through the heart, and we're actually getting into the left ventricle here. And because we're so far down into the left ventricle, we have to presume that because the left ventricle actually creates the apex of the heart, and it's the most inferior portion of the heart, that we're getting down through the heart. And we're not, we've already left behind the ascending and the aortic arch. And so that is long since past, and we are actually going down through the aorta. So that's something to keep in mind there, how you can really kind of define that. Also, we do see that we have the right atrium here, the left atrium, left ventricle, and the right ventricle. If we look between the ventricles, we see that we have this big line here. This line, let me remove this so you can better see it again. This line is the interventricular septum. And so it separates the right ventricle from the left. So it's like a wall that's built there so that the blood, the deoxygenated blood, doesn't mix with the oxygenated blood and just mess everything all up. We do see that we have the right atrium and the right and the left atrium. And so based on that, we have the right atrium here, left atrium here. And let me remove that again. And we do see that we have this line running here as well. And so that's the interatrial septum. Another key thing to point out here is that we do see that the heart kind of has this wide appearance, but not really. We do see that we have a great amount of white here in the right atrium, and we also do have a little bit of white here in the right ventricle. However, notice that the left portion of the heart really doesn't have all of this contrast in it. And that's simply because we are injecting, and so the heart is getting a little bit of contrast, but we're still dumping it into the right atrium. And so it's crossing over into the right ventricle. And so we're not seeing a great amount or a great flush of contrast here. That's just a side note. Also, we do have the tricuspid valve. And remember, the tricuspid separates, excuse me, it's on the right side of the heart. And the left side of the heart has the bicuspid, which means 2 leaflets. And so the reason we can really assume that we can't get clear definition of the leaflets or anything like that from this just straight out axial image. However, we do see this line here, and that is the tricuspid valve that is separating the right atrium from the right ventricle. So keep that in mind, and that's where your knowledge of where things are flowing from the heart actually come in handy and actually start allowing you to build upon that foundation. Okay, this image actually becomes a little more complex. Just notice the location here. In reference to our side images on your left, we do see that we are up a little higher going towards the base of the heart. And we do see several things here. We have the superior vena cava here, which is incredibly white, which really indicates to us that there is a contrast bolus being pushed here, and it's actually dumping into the right atrium. We also do see that we have the ascending aorta and the descending aorta here. And so we've kind of went a little lower than the aortic arch, but we're still catching where it's coming out of the left ventricle and actually pumping up. And so we're catching both the ascending and the descending aorta here. Another thing to keep in mind, which possibly is a little more difficult to really discern what you're looking at here, is the pulmonary trunk. And so based on the amount of contrast in this, it would probably be safe to assume that this is probably an examination for pulmonary embolism to really highlight the pulmonary arteries. But this image is not really that great for demonstrating the pulmonary arteries. And so pretty much in terms of this image, you can kind of scratch that off. And so don't worry about the pulmonary trunk on this image, because if I wanted you to know this, then I would supply you with an image just a little farther down below that, so that you could actually differentiate where the pulmonary trunk is in relationship here. Or actually supply you with images above and below it, so that you can really see what I'm wanting you to grasp. But here we do see several other things, which is, number one, the left atrium here. And notice how it's on the posterior portion of the heart. Remember that we said the right atrium is really anterior, and the left atrium is posterior. Remember ant and post. And so we do see another thing that really gives it away where we're actually looking is these things that kind of go out like this. And at first glance, you may be wondering what is actually going on here. But these are your pulmonary veins. And so notice that we've got a little bit of contrast enhancement here, but nothing like we have here. And so we're still getting a bolus into the pulmonary arteries, and it's going out into the lungs and actually coming back through the pulmonary veins. And so we do have the superior pulmonary vein, which is here, the inferior pulmonary vein here, and so that corresponds to both sides. And if I want you to specify which side it actually is, then I will give you an image that has left and right. Also, take note that there is a typo here. This is left inferior pulmonary vein, which is kind of crazy because you're supposed to have 4 pulmonary veins, and we have 1, 2, 3, and then it doesn't even label really the 4th one. But you can't have right and left being on the same side. It just doesn't really work out. So this one here should be right inferior pulmonary vein. But if I do expect you to tell me which one is which, I will supply you with images that actually tell you left and right, because I think sometimes that is very easy to get confused, and many times you have to refer to these little designations like that. Also, we do see that the image actually has the main coronary artery labeled. However, it is very, very difficult to actually understand where we're looking at, and we won't worry about those as well. And so kind of just X those off, because I feel that that is very, very difficult for you to discern on this. A radiologist would probably have a very difficult time discerning what is what, and so it kind of is difficult for the book to actually define what is part of the coronary arteries that you're actually looking at. So don't worry about that. But everything else, try to take note of and study for our examination. Okay, on this image, we also should understand that we're really inferior in the heart now. We're actually going out of the heart and coming through the diaphragm and going into the liver. We see that in this area here, where we're leaving the diaphragm and seeing the liver actually come into our field of view. We also should take notice that we have the descending aorta here, and then something that really isn't designated in this image, but we will talk about it later, is the azygos vein, which you can see here kind of having a little bit of contrast in it. This is what kind of connects the inferior and superior vena cava together and allows them to communicate and blood to flow. In a certain venous system. We also do see that we have the esophagus here. And so if we're seeing the esophagus really well and defined like this, then we know that the stomach is not very far away, and so we're really getting almost into the abdominal cavity. One thing to take notice here is that we do have the heart, and this is the apex of the heart that we're getting ready to see. But you also do see a structure surrounding the heart kind of like this, and that is the pericardial sac still in play. But here we do see that we have the left ventricle and the right ventricle. And so we do see this line here once again, as kind of better demonstrated on this image. And that is the intraventricular septum. But we do have the right and the left ventricles. And notice how just by looking at this, the right seems like it has more musculature. But we really see it kind of played out in terms of looking at the myocardium, which the myocardium is this area here. And we don't really even see the myocardium as much on the right ventricle, but we do see a lot of it on the left ventricle. I hope that you can see it, that we do have like what looks to be a contrast area here, and then behind that we do see that we have the myocardium. And so based on this musculature, we understand and grasp the importance of the left ventricle. We do see that we have the epicardial fat, but we're not going to worry about that, so just kind of strike that from what you actually need to know. But know the pericardium and the pericardial sac, which I pointed out to you just a few moments ago, and the myocardium and the left ventricle and right ventricle, and also the interventricular septum. That becomes important to know here. So here's a drawing of the heart that you can really just kind of grasp where things lie. We do see that we have the interatrial septum and the interventricular septum here. And notice how it's kind of like a wall here. Also take note of how the myocardium here and here is different. Notice how thick it is on the left and how much thinner it really is in terms of the right. And also notice that we have the tricuspid valves on the right side being in this area, and we do have the bicuspid valve here. And pretty much that just kind of allows you to see where everything is. Also, we do see that we have the superior vena cava here and the inferior vena cava there. And so it's kind of demonstration to how the right ventricle actually fills up and pushes everything through. And other than that, we really don't want you to know very much from this image, because once again, you're not going to see an image like this on CT. Because due to heart motion and things are never going to really be as clear defined unless you're doing gating, so that you can actually time the scan in an appropriate manner so that you get a clear defined picture of the heart. However, you're not going to see a drawing on CT. And so what I would like you to keep in mind here and just kind of memorize is the tricuspid valve, the interatrial septum, the interventricular septum here, left ventricle, right atrium, left atrium, bicuspid valve, and then also the myocardium, and just be able to show me or understand what the difference is between the myocardium on the left ventricle and the right ventricle, and how they are so much different. This image is almost similar to the one that we saw previously, to where we have scanned past the aortic arch, but we do see the ascending and descending aorta. So we do see the ascending aorta here and the descending aorta there as well. We do see that we have the pulmonary trunk, but once again, it's not easily defined, so we're not going to worry about the pulmonary trunk on this image. I think that the next image really designates and demonstrates the pulmonary trunk a little better. We do see that we have the right atrium here, and another thing that kind of gives the right atrium away is that located almost next to it or on top of it is the superior vena cava. So the superior vena cava usually is a very clear sign that the right atrium is getting ready to come into view. Also, that we do see that we have the left atrium here in this general area. Although we don't really see the pulmonary veins very well, we have the right pulmonary vein, but we're really not designated it as superior or inferior. We just say that it's the right pulmonary vein. However, if you'll know that it is the pulmonary vein on this, you will almost assuredly understand that this is the left atrium that the pulmonary veins are flowing into. So that becomes very paramount for you to understand. So pretty much from this image, just really understand all of the other things that are highlighted here aside from the pulmonary trunk. So all the other anatomical structures are very necessary for you to understand. Okay, on this image, we do see a more clearer portion of the heart, and we kind of get all of the anatomical structures in one foul swoop here. We see that we have the right atrium, the left atrium, right ventricle, and left ventricle here. So we do see that we have all of the key anatomical structures for the heart here. Also, I would like you to take notice that, notice here, we have what looks to be something surrounding the heart, and that would be the pericardial sac. Also, we do see that we have the myocardium being thickened here as well. And so we do see bits and pieces of the pericardial sac also with the myocardium. We also do want to take notice that we have a pulmonary vein here, and then we do have a pulmonary vein here as well. So we're seeing the inferior pulmonary veins and not the superior pulmonary veins in this image. Also, we do have the interventricular septum here, and the book does point out that we have the mitral valve, which is on the left side, which would be the left AV or the bicuspid valve. But it's really hard to designate and delineate between all of these structures on this, and so we'll not really worry about it because I really can't discern where this arrow is pointing at, and because I really can't discern any certain structure that the arrow is pointing at, I don't expect you to either. However, the other structures are fair game and are very easy for you to really pick out and understand. And also know that where the blue line is, that's the intraventricular septum. So the great vessels. We must first begin with the aorta. The aorta is the largest artery of the body. Thoracic aorta is what the aorta is called while in the thoracic cavity. However, when it enters into the abdominal cavity, that's what the aorta is called, the abdominal aorta. So notice that we're still talking about the same vessel, but we do change our proximity of where it's, or we change our delineation or name of it depending on where we're actually at in the body. So if we're in the thoracic cavity, it becomes the thoracic aorta. If we're in the abdominal cavity, it's the abdominal aorta. However, notice we're still talking about the same vessel, and it hasn't really diverged or become something new. It's still the same vessel, just in a different location. We also see that we have the ascending aorta, which is what the aorta is called when it begins at the base of the left ventricle. And so if we'll remember, we have the left ventricle, and the aorta actually comes up from the left ventricle and kind of looks like this. And then we saw on the images that we had over here the descending aorta as well. And so somewhere in between the ascending and the descending, we make a curve which changes the aorta from going up to going down, and that is called the aortic arch. It's the superior portion of the aorta, and it's located at the root of the left lung. Also, we do have the descending aorta, which is what happens after the aortic arch. And after the aortic arch, and we get into the descending aorta, is when we start labeling it as thoracic and abdominal aorta. Also, we do have the ligamentum arteriosum, which is a fibrous cord that attaches the pulmonary trunk, to the aortic arch. And it's a remnant of fetal development. And basically what this does is serve as an anchoring point for these structures so that they are not moving and creating wear and strain on things, and pretty much anchor them in the body so that there is lesser chance for tearing and ripping sensations here. So even though we've already talked about this and kind of discussed it in full, we still need to review once again the pulmonary circulation. Right pulmonary artery, which we saw coming out from the pulmonary trunk, is in charge of supplying deoxygenated blood to pretty much the right lung for oxygenation to occur. It's posterior to the ascending aorta and anterior to the esophagus and right mainstem bronchus and hilum of the right lung. And so just remember that, and this will help you kind of distinguish where the right pulmonary artery is. So just remember this. The left pulmonary artery, as we said with the right pulmonary artery, is in charge of supplying deoxygenated blood to the left lung. We have to take notice that it's shorter and smaller than the right pulmonary artery. However, it's more superior than the right pulmonary artery, and it travels horizontal over the left mainstem bronchus. And so what we mean by being more superior is that if you were standing the patient up, and this being the head, and this being the heart here, we would see that the left pulmonary artery, which this would be left and this would be right, the left would be slightly higher than the right. And so in terms of axial scanning, you should see that the left comes in your scanning field before the right. Also, we see that the left travels horizontal over the left mainstem bronchus, whereas the right does not. And so that goes back to the way that it's kind of laid out in the body. As we saw before, we had the right kind of making this curve like this, and the left kind of doing something similar to this. And so that is what we're really talking about here. So the right superior pulmonary vein. It collects blood from the upper lobe segments of the right lung. It passes anterior and inferior to the right pulmonary artery and behind the superior vena cava. The right inferior pulmonary vein collects blood from the right lobes of the lower lung, and crosses behind the right atrium to the left atrium. The thing to keep in mind here is what they're collecting blood from. The right superior collects from the upper lobe, and the right inferior collects from the lower lung or the lower lobe lobes of the lung. The left superior pulmonary vein collects blood from the upper lobe of the left lung, and it courses anterior and inferior to the left mainstem bronchus. The left inferior pulmonary vein drains the inferior lobe of the left lung and is anterior to the bronchi. And so just remember here that the left actually collects blood from the upper lobe, being in the superior pulmonary vein, and the inferior pulmonary vein collects from the inferior lobe. That causes us to go back to the lungs and remember that the right has 3 lobes, left has 2 lobes. And so when we split this up, we see that on the right side, the superior collects from just basically the upper lobe, and the inferior pulmonary veins collect from 2 lower lobes. And so keep that in mind, and it will become much to your benefit in relationship to what is actually collecting blood from what. And so if you can keep the right side straight, then the left side instantly makes sense, because if you remember that the superior on the right side collects from the upper lobe and the inferior collects from the 2 lower lobes, then you're going to instantly know what the left superior and inferior pulmonary veins do as well. And so everything kind of hinges on the right side. So this image is very similar to the ones that we've actually been looking at before. We do see that we have the ascending and descending aorta, which I'm sure by now you can instantly recognize. We do also have the pulmonary trunk coming here, the right and the left pulmonary arteries. We also do see that we have the superior vena cava. One key structure that I would like you to really recognize, and it's not even labeled, is we have this and this, which are the left and right mainstem bronchi. And so it becomes obvious that we've actually just, the corona has actually split, and we have started going into the right and left lungs. However, there is a structure posterior to it. Let me erase that and see if I can draw it just a little better. And you see that it's air-filled. And my question would be, what is this structure? It's not labeled on here, but it's something that I would like you to just keep in mind where things are, what things are, as we're actually going through the thoracic cavity. This is the esophagus. As we can see, we've already passed the corona, so it can't be the trachea, and so it has to be the esophagus. And notice the proximity. The esophagus sits just slightly to the right of the descending aorta and right in front or anterior to the azygos vein, which is right here. So as we look at this structure and look at this image, I feel pretty confident that each of you can actually look at this image and pretty much pick out each of these things. And so pretty much know every one of these structures for this image, as it will prove essential from this point out. Okay, on this image, we do see that we are just slightly a little more superior. And one thing to keep in mind that we had already spoke of is that the left pulmonary artery, which would be on this side, actually is a little more superior than the right pulmonary artery. And so we see that actually bared out in this, because we do see that we have the left pulmonary artery coming in before we do the right. Also, we do see that we have the corona, which is actually happening here. We do see the divergence, and so one is actually becoming two, so the trachea is actually splitting into the left and right mainstem bronchus. We do see that we have the ascending and descending aorta once again here and here. Also, we do have the superior vena cava, which is there, and we have the sternum, which based on this location, we really don't know where the sternum actually is. We presume it to be past the sternal angle and actually working on the body of the sternum. However, that is of really no consequence for us at this moment. Also, we do see that there is a structure just posterior to the corona here, which is the esophagus. However, it's very hard to designate and delineate between just a soft tissue random structure and this. And so we're not going to worry at this point about the oblique fissures because they're very hard to really distinguish on this image. And the posterior segmental bronchus, the right superior lobe bronchus, and the anterior segmental bronchus, and so pretty much each of these things that I have completely just wadded out, don't worry about noticing or memorizing. You can look at them and try and distinguish those from each other, but you're not going to be expected to memorize this in terms of the examinations that we will have. So don't really worry about those structures because in terms of this image, they're very hard to see and distinguish between one and another. So the vena cava. The superior vena cava is formed by the junction of the brachiocephalic veins and it carries blood from the thorax, upper limbs, head, and neck back to the right atrium. It's posterior to the right first costal cartilage and posterior and lateral to the ascending aorta. And so there's just a few things to keep in mind where it actually returns blood from. So keep that in mind. And that it is lateral to the ascending aorta. And when we mean lateral, it's going to be on the right side of the ascending aorta. And so those things become very important to actually note so you can distinguish the superior vena cava. So the inferior vena cava. It's formed by the junction of the common iliac veins in the pelvis. It's right of the abdominal aorta, and so you will always see that the inferior vena cava is always slightly to the right, and it's anterior to the vertebral column. And so if we were to actually draw this out, we have the vertebral body here, and we would have the abdominal aorta over here, and we would have the inferior vena cava here. And pretty much notice that this is the right side, this is the left. Also think about what is on the left side or on the right side. The liver would be coming in something like this, and so you would see the inferior vena cava actually coming through the liver as it comes up into the right atrium. So keep that in mind that the inferior vena cava is going to be slightly more on the right side than what the abdominal aorta is, and so it's going to be right in front of the vertebral body, and that will help you distinguish one from another. So the branches of the aortic arch. We have the brachiocephalic, or the nominate trunk. It's the first major vessel and the largest branch arising from the aortic arch. It ascends obliquely to the upper border of the right sternoclavicular joint, and it divides into the right common carotid artery and the right subclavian artery. The right common carotid artery divides into internal and external carotid arteries and ascends the neck lateral to the trachea to the level of C4. The right subclavian artery supplies blood to the upper extremities, and it curves posterior to the clavicle in the axillary region. The left common carotid artery is the second vessel to branch from the aortic arch, and it arises just behind the left sternoclavicular joint and ascends lateral to the trachea and divides at C4. The left subclavian artery supplies blood to the upper extremities and arises from the aortic arch posterior to the left common carotid artery. It arches laterally toward the axilla. The internal thoracic arteries supply blood to the anterior portion of the thorax and creates an anastomotic pathway between the subclavian artery and the external iliac vessels in the event that the descending aorta is blocked. So here we have an image that clearly defines the branches of the aorta as they're coming off of the aortic arch. We do see that we have, or we can label this as 1, 2, and then 3. And so if we go one by one, we see that we have the ascending aorta coming up here and reaching the aortic arch. And so our first branch that actually comes off is the brachiocephalic or innominate trunk. And as we continue on, the brachiocephalic trunk actually merges, and we have a branch coming off, which is the right subclavian, and it continues on straight up as the right common carotid artery. So the right brachiocephalic trunk pretty much diverges, and one becomes the right subclavian, and the other part becomes the right common carotid artery. If we look at going towards the left side, then we see that we do have two branches here. One is the left common carotid artery, which is branch 2, and then branch 3 is the left subclavian artery. So if we will think about this and label it as 1, 2, 3, then that will help us keep it straight when we actually look at images of this in a further degree. So if we look at it from an axial perspective and not a three-dimensional, we see that it becomes slightly more difficult to actually discern what is what. One thing to keep in mind is that the arteries all lie kind of in a cluster here, and there's this one outlier here that is a vein. Also notice that the vein is a little larger than the artery, and so that will help keep things in perspective here. But notice that we have the right and left brachiocephalic veins and how much larger they really are. So keep that in mind. But we do have the right brachiocephalic artery, the left common carotid artery, and the left subclavian. So if we look at this, we have 1, 2, and then 3. And it all kind of goes in this half moon shape, something like this. And so we start off at the vertex or the top point as 1, and then we come down to 2, and then we get 3. And so looking at that, hopefully that will help keep things in perspective there. Also remember that the brachiocephalic, the right brachiocephalic or innominate trunk becomes the right subclavian and the right common carotid. So everything's wrapped up in that, and we've not actually got to the point where they diverge yet. But in terms of this image, I feel that that is pretty much it for the thoracic cavity in terms of anatomical structures for this image. So, tributaries of the superior vena cava. We have the internal and external jugular vein, the subclavian veins, which arise from the axillary veins, which receive blood from the external jugular veins before uniting with the internal jugular veins. So the internal and external jugular veins and subclavian veins play a very detrimental role in the superior vena cava. Also, we have the left brachiocephalic vein, which courses across the midline anterior to the branches of the aorta. The right brachiocephalic vein, which unites with the left just posterior to the costal cartilage of the first rib. And then we have the superior vena cava, which originates from the union of the left and right brachiocephalic veins and dumps deoxygenated blood into the right atrium. And so if we actually refer back to this image, we actually see that this is kind of bore out in that sense. We do have the left and the right brachiocephalic vein, and they are getting ready to join and become the superior vena cava and dump into the right atrium. So this structure here becomes very important. So that brings us to the coronary arteries. It's very important that we understand right and left coronary arteries, and so that we can understand how everything kind of goes together. If we begin with the right coronary artery, and keep in mind that this slide is simply for the right coronary artery, we see that we understand that the right coronary artery supplies the right atrium, right ventricle, and interventricular septum in the SA and AV nodes. So the right coronary artery is very important. If we begin with the right coronary artery, we see that we have the coronary groove, the right marginal branch, posterior interventricular groove, posterior interventricular branch, and then an anastomosis with the LAD. And so that's kind of a lot to keep straight, and hopefully we can demonstrate this better in the coming slides. So the left coronary artery, it supplies the interventricular septum, including the AV bundles and most of the left ventricle and atrium. And so if we look at this, it instantly appears that the left coronary artery really doesn't play as detrimental a role because it really doesn't supply as much. But if we look at what it does supply, we see that it's the left ventricle and left atrium. And so the primary pumping mechanisms of the heart being the left ventricle, and the left atrium is in charge of getting the left ventricle the oxygenated blood. If we don't have good blood flow to the left ventricle, then the heart ceases to really function at all. And so this is what makes the left coronary arteries very detrimental. So we have the left aortic sinus is where we begin. Then we have the left coronary artery, and it has a division into the circumflex and the LAD. And the circumflex becomes the left marginal artery, and then we have the cardiac veins, which help to return the blood back into the right atrium. So the coronary veins. The coronary sinus is in charge of returning most of the venous blood from the heart. It's located along the posterior section of the coronary sulcus and terminates at the right atrium. The great cardiac vein is the main tributary of the coronary sinus. It receives blood from the left posterior ventricle vein and the left marginal vein. It arises near the apex of the heart. We also have the small or the right cardiac vein, the middle or the posterior cardiac vein, the left posterior ventricular vein, the oblique vein of the left atrium, and the anterior cardiac vein. We won't worry so much about all of these smaller tributaries. We just worry about the coronary sinus and the great cardiac vein. So know both of these very well and what their function really is. So here we see that we're looking at the left coronary artery. We see that it begins with the left coronary artery and then divides here. As it divides, we see that we have one area go this way and the other area actually continue down like this. This division here is the circumflex or left coronary artery circumflex. And this is the left anterior descending coronary artery, or the left anterior descending artery as this is called, or the LAD. As we can see, it is in charge of supplying most of the left ventricle. Very important. If you do not have great blood flow here, then most assuredly your heart will cease to pump, and that's why it's so detrimental that if you have a blockage here, chances are it's not going to work out real great for whoever is actually having this blockage. prognosis is very dire for these situations. So in terms of this image, know that we have the left atrium here, and which would mean that this is the left ventricle here, and the LAD, the circumflex, and the left coronary artery. And we won't really worry about the ascending aorta because it really doesn't look like much of an ascending aorta when there is no aortic arch or ascension there. So just worry about the other structures here. Perhaps this is the best image of the coronary arteries that we can acquire using CT because it lays it out very well. Notice that we don't have any bifurcation here or anything. It really is just the right coronary artery. So we have the right atrium here and the right ventricle here. And going in between, we have the right coronary artery. Also take notice that we have the ascending aorta here, and the right coronary artery is branching off of that. It's very important to keep in mind that the coronary arteries do not carry deoxygenated blood, therefore they have to branch off of the aorta. And it's because they branch off the aorta that they can actually supply the heart with oxygenated blood, just like they can supply other portions and other cells throughout the body with the oxygen. This brings us to our last topic, which we've already kind of discussed as well, which is the azygos venous system. It provides collateral circulation between the inferior and superior vena cava and can be divided into the azygos and hemiazygos veins. It's in charge of draining blood from most of the posterior thoracic wall, bronchi, pericardium, and the esophagus. So it's very detrimental that the azygos venous system function properly as well. And if we're looking at this image, I think we've had some that are actually better quality than this. But I do want you to keep notice that we have the ascending, the descending aorta here. We have the pulmonary trunk here, which is dividing into right and left pulmonary arteries. We do have the corona branching here and here into left and right main stem bronchus. We do have the esophagus, which is sitting slightly posterior to the corona in this area. And then posterior to the esophagus, we have just anterior to the vertebral body, where the line is actually pointing, is the azygos vein. The hemiazygos vein actually sits posterior and left of the vertebral body and posterior of the descending aorta in this area here. However, we don't really see it demonstrated very well. What we tend to focus on is the azygos vein. Just know where the hemiazygos vein is actually located. Once again, posterior to the descending aorta and to the left of the vertebral body is where you should find the hemiazygos, but mainly know where the azygos vein is located, posterior to the esophagus and just anterior and right of the descending aorta and posterior and anterior to the vertebral body. And if you keep these straight, then pretty much all of this will tend to start making sense.